This is the third lecture of the anesthesia for left side obstructive lesions. We'll continue, we'll talk about the interrupted or hypoplastic aortic arch. Interrupted aortic arch. There are types. Distal, type A is the interruption is distal to the great vessels. So the arch branches into the great vessels and then is interrupted. And the descending aorta is PD dependent, with PD dependent lower body. Type B, the left common carotid and the left subclavian. The arch brings the branches into the left common carotid and the left subclavian. And the type B is between innominate and left common carotid. So in type B the interruption is not like here is not after the great vessels but between the left common carotid and the left subclavian. And type C is between the innominate and the left common carotid. Usually other anomalies, mainly VSD and or left LV outlet, LVOT obstruction, posterior deviation of the canal septum. Preoperatively, the patient is usually asymptomatic at birth, but congestive heart failure and lung congestion with closure of closure of ductus arteriosus. Prostaglandins, resuscitation, and urgent surgery to prevent ischemia of the lower body. One-stage repair in neonates is preferred over a two-stage repair with the pulmonary artery band. One-stage repair with arch repair using descending aorta advancement. Using the cardiopulmonary bypass, deep hypothermic circulatory arrest with antegrade cerebral perfusion, so that we can advance the descending aorta and suture it with the arch to connect the descending aorta with the arch. Other anomalies are addressed. For example, the ASD closure. In case of LVOT obstruction, either Yasui operation, which is an arch repair plus a DKS, Norwood, then later Yasui, or Roscono according to the condition of the patient. We will explain these later. Intraoperative, in case of pulmonary congestion, avoid decrease in pulmonary vascular resistance, increase FiO2 and avoid hyperventilation. The arterial line should be preductal, usually the right radial artery or the right axillary artery. Right subclavian artery may be anomalous from the descending aorta, and left subclavian artery may be used during repair. So we should keep these in mind. We should examine the CT of these patients before induction of anesthesia to put a plan for the lines and where to insert the arterial line, and to consider whether this line would be compromised later during bypass or after bypass. Umbilical artery may be needed. Neonatal cerebral oximetry. Because of the surgery itself is at the arch, because of the deep hypothermic circulatory arrest, so we should monitor the cerebral perfusion by the cerebral oximetry. Post cardiopulmonary bypass bleeding is expected. Irradiated blood and monitor calcium level for DeGeorge syndrome. Residual pulmonary hypertension should be managed. Post-operative transfer to ICU with open sternum and stents is common. due to the length of the operation and the many suture lines, so that bleeding is common in these patients. Also the suturing and surgery is in the arch, so the arch is a high pressure artery, so bleeding is common in these patients. Talk about Shone's complex. Shone's complex may be supravalvular mitral ring, parachute deformity of the mitral valve, subvalvular aortic stenosis, coarctation of the aorta, plus or minus bicuspid aortic valve, VSD or mitral stenosis. So there is stenosis all the way starting from before the mitral valve till after the aortic valve. So it is supravalvular mitral ring, parachute deformity of the mitral valve, subvalvular aortic stenosis, coarc, bicuspid valve. So the entire left heart is stenotic generally. Parachute mitral valve is a valve with only one papillary muscle, short chordae, and mitral stenosis. So only one papillary muscle that collects the cusps. So the cusps become tethered with a limited opening, causing mitral stenosis. In supravalvular mitral ring, the left atrial appendage and fossa ovalis are proximal to the membrane. In contrast to the Cor-triatriatum, this is the position of the Cor-triatriatum, that is distal. So the fossa ovalis and left atrial appendage are distal to the Cor-triatriatum membrane. But in supramitral ring, the ring is just above the mitral valve, so the left atrial appendage and the fossa ovalis are proximal to the membrane. This is the parachute mitral valve, and this is how it is. The surgery is done. Preoperatively, we check the echo, the CT, and MRI. Cardiac catheterization can be used to detect the presence of multiple levels of stenosis in series. Pulmonary congestion, pulmonary hypertension, duct-dependent systemic circulation are important factors that need to be diagnosed before starting the case. For multi-level stenosis, sometimes it is difficult to measure exactly the gradient across each step in multi-level stenosis, because when we put a continuous wave on the LVOT, it will measure the total gradient of the LVOT. But to be able to specify the gradient across each obstruction, we may try to put pulse waves at different levels on the LVOT, or better to do a cardiac cath and pull the catheter from one level to another and measure the pressure directly at each level. Surgically, early repair of the mitral valve, subvalvular aortic stenosis with resection, cono or Ross cono, and coarctation. Relief of one level of stenosis may reveal another undiagnosed level of stenosis. Cardiac cath is useful to diagnose multi-level stenosis and pulmonary hypertension. This is the cono operation, or the modified cono. When there is a subvalvular stenosis, we open the RVOT, and then we expose the LVOT, and then open the LVOT. We put a patch on the LVOT, and then we put another patch on the RVOT. So we widen both the LVOT and the RVOT. A Ross cono is a cono plus a Ross operation, in which we replace the aorta of the pulmonary. We take the healthy pulmonary valve of the patient and put it on the aorta. We take the pulmonary valve, put it on the aorta, and then we take a tissue valve, a freestyle or homograft, and put it in place of the pulmonary artery here. So this is a Ross cone. We take the pulmonary artery of the patient. This is the pulmonary artery of the patient, and then we open the heart, and when we open the RVUT and the LVUT to widen the LVUT, and then we put the pulmonary valve with a part of the RVUT as a patch for the LVUT. So instead of just a patch for the LVUT, we include with it the pulmonary valve. So the pulmonary valve replaces the aorta here, and this tail is considered the patch to widen the LVUT, and then we implant the coronaries in the new aorta, and then we bring a RV conduit or a freestyle or homograft in place of the pulmonary artery. Mitral stenosis, usually part of the Shone's anomaly in children. Type A, normal papillary muscle, commissural fusion, a valvular or supravalvular ring, or an obstructive left superior vena cava. In type B, anomalous papillary muscle, parachute, or a hammock mitral valve. These are the variants of the Shone's anomaly. The left superior vena cava usually connects with the coronary sinus and widens the coronary sinus, because the left superior vena cava drains into the coronary sinus and then through the coronary sinus to the right atrium. So if the coronary sinus gets much enlarged, it may compress the mitral valve, causing stenosis. Preoperatively, lung congestion, later pulmonary hypertension, low fixed cardiac output. Surgical repair is preferred to allow growth and avoid anticoagulation. Resection of supravalvular ring, commissurotomy, division or reconstruction of the papillary muscles, and the reconstruction of the chordae tendineae. Balloon dilatation may be useful. All these to avoid mitral valve replacement in a child in a young age. Because replacing a mitral valve at this young age with a tissue valve would render the patient indicated for further multiple redo mitral valve replacements in the future, which is high risk. And if we replace it with a mechanical valve, so the patient would need to be on anticoagulation from this young age for life, which is annoying for the patient, and it's especially risky for young women in the childbearing period. Intraoperatively, we avoid tachycardia and hypovolemia, decreased cardiac output, maintain afterload and low normal heart rate, avoid hypervolemia, increases congestion, and also avoid dehydration. Attempt to reduce pulmonary vascular resistance may paradoxically worsen the condition due to fixed downstream obstruction. This is similar to the obstructive total anomalous pulmonary venous drainage, the same paradox. Arrhythmogenic due to left atrial dilatation. With pulmonary hypertension, 100% oxygen, low normal PCO2, avoid acidosis, hypothermia, hypoglycemia, stress and pain. Inodilators and pulmonary vasodilators may be needed. But as we said, in some cases, reducing the pulmonary vascular resistance may paradoxically worsen the congestion. So the best management for these patients is surgical to correct the pathology. TE post residual gradient across the mitral, iatrogenic significant mitral regurg, the airing after repair. Cor-triatriatum is an obstructive membrane in the left atrium. The left atrial appendage and the fossa ovalis are distal to the membrane, as we said before. The pathology is dependent on the degree of obstruction. Pulmonary symptoms like wheezes may be the only presentation. The pathology and management are similar to the mitral stenosis. Thank you.